I'm honored to then introduce our next speaker, which is Dr. Richard Lisman, who's an ophthalmologist, ocular plastic surgeon. He's been doing craniofacial reconstruction for many, many years. Highly experienced. We're happy and to have him on our team because he provides a lot of insight, a lot of expert advice for our patients and treatment. And I've done many cases alongside with him, so happy to introduce him as our next speaker. Thank you very much.
Good morning. My name is Dr. Richard Lisman, and I'm going to present an overview and a generalization of where ophthalmology overlaps with our craniofacial patients. My field is called ophthalmic plastic surgery. It's where ophthalmology and plastic surgery overlap. It has very little to do with the interior of an eye and everything about the orbit. Now, as you've heard and will continue to hear, that our Tessier craniofacial clefting nomenclature surrounds the orbit. The orbit is where ophthalmic plastic surgeons reside, and I'm going to just present this overview of where our field comes into play. The mid-clefting syndromes that occur down mid-face almost always intersect with the tear outflow system, the nasolacrimal duct and the canaliculi. As you can see from this photograph and slide, it also overlaps with lower eyelid defects, absences of tissue in the lower eyelid, absences and separation of bony unions in the orbit. So those clefts that occur down the midline usually come into play in our small subspecialty. Now, when you look at the clefting syndromes that occur mid-face, you're almost always intersecting with the lacrimal sac, the lacrimal outflow system, and the channels that lead to the lacrimal sac. If you think of tearing as purely an aesthetic phenomenon, you're incorrect. Tears that pool within the palpebral aperture are like a stream that can't flow. They overgrow bacteria, they overgrow fungi, they overgrow algae, and you have a patient with a chronic infection. Let's press on. So midline clefts may not always interfere with the nasolacrimal duct, but it often does. Eyelid epicanthal folds, soft tissue that overlaps with the medial portion of the eyelid, produce an appearance of a widened palpebral aperture or telecanthus, and often push the cilia, eyelashes, onto the globe. It's as if someone had stuck a finger in your eye and you're constantly having a foreign body sensation or epiphora, which is tearing. Now, the nasolacrimal system is the narrowest channel in your body. It's not a millimeter wide. The entrance is 0.6 of a millimeter, and further down the ingress, the canaliculi, it's again a fraction of a millimeter. So some youngster who appears to be tearing purely isn't emotional. It is the lack of egress in, excuse the nomenclature, but the plumbing system of the eye. The tear ducts go down 2 millimeters and over 8 in both upper and lower system. Approximately 20% of patients do not have one union into their lacrimal sac, and the lacrimal sac is the egress entering the nasolacrimal duct. I'm going to show you the next image is of a Dacreus cystogram. Now, this is rarely performed in children because you'd have to sedate them to do it, but the occasional very compliant child can have it done. And a dye is inserted into the nasolacrimal duct to see where the defect resides, or if there is even a defect and not a total absence of tissue. Normally, in the early first year of life, the nasolacrimal system exits under the inferior turbinate. and it proves to be imperforate. It doesn't totally open, but almost all children have them open within 10 months or 12 months, but not in craniofacial patients because they're usually missing the tissue to exit under the inferior turbinate. Now, the difference being that a child that has a completely formed nasolacrimal duct can simply have it probed and pushed through to open that system. But if portions of it are missing, as they often are, that's a more detailed reconstruction. Now, with apologies to our cardiac specialists, in our field, we stole Lacrocasts, which are balloon catheters, 10 years ago from our angioplasty specialists. This is a balloon catheter that's a fraction of a millimeter, and they're much, much smaller than our invasive cardiologists use. And a Lacrocath, in most patients who simply have an imperforate membrane at the end of the nasolacrimal system, a Lacrocath can be introduced, blown up to create that opening. But that opening can't be left alone, as in an angioplasty, we don't have a coil that you can place in there. We have lacrimal microtubes, which are solid core tubes to keep that opening perforate. And they usually stay a year or two. And when they're in there, they're not like a straw that conducts tears. They're a solid core catheter that maintains the opening. So what's the outcome if one didn't open a nasolacrimal system? As with any stream that can't move, the lacrimal sac will blow up, and as here in this one image in an adult, a shutoff occurs at the entrance to the nasolacrimal duct and to the common canaliculus, producing an abscess. Now, this is not that common in children, but yes, you will see craniofacial children appear with a mass in the medial canthus, and there's nothing else that resides in the medial canthus. It's the lacrimal sac, which is blown up like a balloon. That is an abscess. That's just a source of other periocular infection and needs to be opened. Now, when you take a look at other presentations in these children, it's not uncommon to see upper eyelid retraction. Most upper eyelid retraction in adolescents or in adults is Graves' disease, is a thyroid ophthalmopathy. It's a over response to one muscle in the upper eyelid called Mueller's muscle, which is a sympathetic muscle. And then it's a secondary inflammation that produces scarring and cicatrization to hike up the eyelid. But in craniofacial patients, this is what I'd mentioned previously. You can see lashes that point down onto the globe and produce constant tearing, infection, foreign body sensation. So a child like this needs his upper eyelids recessed, let down, and the lashes rotated away from the globe. We'll press on to other presentations. This is obviously the ingress of the nasolacrimal system. It's called the puncta. It's not a millimeter, it's 0.6 of a millimeter. And whether you have a benign inclusion cyst, whether you have an acquired cancer, it blocks the entrance to the nasolacrimal system. Other presentations in these children are adhesions, absence of tissue and soft tissue in the lateral eyelid, lateral canthus, and scarring that it produces is known as symblepharon. That's an adhesion between lid and globe. Now, what I haven't mentioned is the tear system isn't an open channel like a straw that conducts tears by gravity, and yes, it can conduct tears by gravity in the upright position, but there's a pumping action to the muscles around the eyelid. There are 3 levels of the orbicularis muscle. It is controlled by the 7th nerve. There's pretarsal orbicularis, preseptal, and orbital orbicularis, and it acts to propel tears and pump them down the eye. Now, in these children, there's very little that we can do to replace that pumping action or the power of that pumping action if it just is absent from birth. So the best hope is to place the tear outflow system, and this is a puncture that's completely closed over, is to place the tear outflow system like a drain in the sink at the bottom of the sink. So at least you'll have some drainage by gravity, but often children with a postoperative open nasolacrimal system still have tearing. And the answer is they do not have that pumping action, that soft tissue that was absent from birth. Now, I had mentioned that there are tubes that are placed in the system. This is an example of what's called a monocanalicular stent. It's a tube that goes through only the system that's blocked, and it's held in place with this plug. It's like a cork in a wine bottle, and this tube is down the nasolacrimal system. But most tubes are bicanalicular. They're put in both systems and exit under the inferior turbinate of the nose. They're often used in children post-trauma. Here is a total lid avulsion. When the lid is pulled away from the medial canthus, it invariably pulls away, tears the canalicular outflow system, and that needs to be reconstructed, and is a relatively low-yield procedure because, as I have mentioned, this is the narrowest channel in your body, and it is not that difficult, and it's not that easy to ask it to open and remain open without later cicatrization or scar tissue. So when you see an adult or a child who has an absent nasolacrimal system, the outcome is a chronic conjunctivitis. It's living with an eye infection, off and on, treating with antibiotics. After removing the blockage, this is a patient who has had their nasolacrimal system open with the microtubes I just showed you. But after removing the tubes, presumably the congestion clears, and the analogy I previously used, it's like a stream that can move once again and isn't brackish and overgrow bacteria. All right, now the second overlap with my specialty is drooping upper eyelids, known as congenital ptosis, spelled with a P. This can be hereditary or it could be absolutely non-familial. One of the more difficult and interesting ones is fibrosis syndrome, and it does occur in a 2% of craniofacial patients, but less than 1% of live births. And fibrosis syndrome, if you look at the parents and all three children, in this particular family, it was an autosomal dominant, they have a chin-up position. And you see a child coming into your practice in a chin-up position, it's because they're trying to avoid the blockage of upper fields of gaze. It's like a horse with blinders. Their blinders are up above, and their natural head posture is chin up, which later produces cervical spine abnormalities, headache, whatever. But this is an example of fibrosis syndrome. Now, blepharophimosis syndrome is a very common overlap with our plastic surgical colleagues. This is a father who had his blepharophimosis syndrome operated upon, and this is his youngster. It can be ptosis, drooping of the upper eyelids, phimosis, which is a shortened palpebral aperture, and lid retraction or ectropion. So this is another very common overlap. But with most congenital ptosis, we tighten a muscle to the upper eyelid, the levator muscle or the levator aponeurosis. And this is, again, an inexact science, can take multiple surgeries, and you'll never get symmetry, but what you'll get is an improved symmetry. But this is different in craniofacial patients. In congenital ptosis, in these small youngsters, they have a levator that is fibrotic, fatty infiltrated, and never really has contractile power. So if you're going to raise the upper eyelids, think of it like raising the sleeve length of your arm. It's not going to hit your wrist any longer. So they do have incomplete closure, globe exposure, and need wetting agents for a long time, if not for life. So most of these kids, you could look at this youngster and say, okay, this is unilateral ptosis. But when you look at the brow position, it's slightly elevated. You look at the other side, and if we were to place our finger over that brow, the other eye is slightly ptotic. So most children need bilateral correction. And as I just mentioned, you don't have the power of complete closure. So one very common way to elevate it is with silastic rods that join the frontalis muscle, which is working, to the levator, which is fatty infiltrated and fibrotic. Because if you look at a silastic rod, it's like a rubber band. You have some snap. So hopefully you'll get a little better closure. This is a youngster who underwent a bilateral frontalis suspension, and you can see the slight incisions over the brow, and that fades with time, but they all mostly need to be redone as the children grow and their face expands, their skull expands. Think of it like a rubber band that's becoming lax and expanding similarly. So again, compare this to a youngster with just a droopy eyelid, a weak muscle. The muscle is tightened and a reasonable result is attained. But in frontalis suspension, which is mostly required in our craniofacial patients, if you raise one and not the other, look at his brow. That brow is clearly higher than the other side. He is unconsciously, involuntarily raising a brow. Now, you try to raise one brow, it could be a party trick where you can hold it for a few moments, but these children are this way constantly because it's not under their voluntary control. So we had a bilateral frontalis elevation, frontalis suspension. And you look at the left eye and you go, well, why did he even need the left eye done? He looked pretty good pre-op because his brows will work symmetrically if both of them are done symmetrically. So the alternatives are silastic rods are very useful in our craniofacial population. One of the more traditional ways, it's an old-fashioned way of doing it, but we still use it, is by harvesting fascia lata from the leg, using that fascia lata to connect from the tarsus, the dense connective tissue plate of the upper eyelid, to the frontalis muscle, and that is allowing the child to elevate that eyelid. But as I said, if it's done bilaterally, you have a better chance of getting symmetry. Now, this again, I'm contrasting it with an older child with unilateral ptosis. This is a levator tightening and not frontalis suspension. Now, one smaller subgroup of ptosis is a misdirected seventh nerve known as jaw-winking ptosis, jaw-winking syndrome, or Marcus-Gunn, G-U-N-N syndrome. So when you have a child or an adult with ptosis, ask them to contract their lower face or mid-face or open their mouth. She opens her mouth, bang, the eyelid elevates. Now you've got a real problem. You have ptosis, but there's no way that you are going to alleviate the misdirection. There are alternatives. One alternative is just elevate the eyelid, and the patient knows that when they chew, when they move their jaw from side to side, their eyelid's going to flutter. Another alternative is to take the levator off and just dispose of it. So there is no input into that eyelid, and then go ahead doing the aforementioned bilateral frontalis suspension using a good forehead muscle, the frontalis muscle. So fibrosis syndrome, when the child presents in a chin-up position, you know that there is visual decline, and they're telling you that they can't see in the upper fields of gaze, which for all practical purposes may not matter, because all of us, when we want to look at the upper shelf, move our chin up and we're looking straight ahead. But if you think your child is going to be a major league shortstop or a basketball player, they need that upper field of gaze, and they're not moving their chin up. They just are hooded in upper fields of gaze. Okay, pressing on to soft tissue abnormalities. Congenital colobomas, where they're missing a section of their upper eyelid, and that's a basic eyelid reconstruction, but the downside is they haven't had the aging changes, the involutional changes to produce enough soft tissue to move over. So once you take an eyelid and advance tissue from the lateral canthus, you're tight. So you're inducing a tethered ptosis, not a congenital ptosis, but it's tethered. And that's secondary surgery to elevate the upper eyelid once that coloboma is closed. The next order of business where we overlap with our microvascular plastic surgeons are free flaps. This was a young man who presented to our emergency room having fell asleep stoned on one of his friend's couches in his living room. And he woke up having that friend's pit bull devouring his upper eyelid and forehead for breakfast. So this was a total loss of upper eyelid tissue. No upper eyelid, no lower eyelid, no forehead that we could borrow from. He had a skin graft to his upper eyelid, but this is a microvascular free flap that was later shaped into rudimentary eyelids. Here he is on presentation. This is one really well done. Not that I did it, but one of our microvascular team did it, placing that free flap in the orbit. And then when you divide it, remember there are no muscles left in the upper eyelid, no levator, no closure muscles. So he's opened and left ptotic because there's a globe back there. So this is not the most wide open eye, but if we had opened his eye widely, he'd never close, his cornea would dry out, his vision was actually excellent behind the loss of soft tissue. Now, just to finish up, there is overlap with our dermatologists, and our dermatologists are not in the craniofacial group, but obviously our craniofacial surgeons and our plastic surgeons have a lot of activity in these kids, whether it's a congenital hairy nevus or whether it's a kissing nevus. You're affecting upper and lower eyelids, and remember I said in the medial canthus, you really could be affecting, after your surgery, the tear outflow system. So this is skin grafts to upper and lower lids, and in time it looks quite good. But if you're a very astute observer, you'll look at it and go, why didn't you remove this pigment at the lid margin, at the mucocutaneous junction? Because this pigment does wrap around the eyelid to the back of the eyelid, and if it were removed, it would be a more major 2 or 3 step procedure. And the mucocutaneous junction is just like your lip. It's where mucous membrane meets skin, and the outcome is it looks like eyeliner, which is just acceptable in a young lady, but not so acceptable in a young man. So with time, these can look quite good, but contrast this to a congenital hairy nevus, whether it's mid-face, forehead. This is a youngster who underwent 8-9 years worth of surgery and stage surgery. And when you look at the final outcome, it's been skin grafted upon skin grafts to upper and lower eyelids, and yes, leaving that palpebral aperture small and ptotic because there isn't a great ability to blink and close. So as each stage is done, the last one is the eyelids. And this was a seeing eye with good vision, but no ability to blink, close, and wet the cornea. So there are significant contour problems, but compared to the significant abnormality initially, it is clearly an improvement, but far, far, far from an eradication of what we started with. So I did mention that at the best of outcome, you are leaving pigment at the mucocutaneous junction. But look here. All of the lashes are absent. All of the cilia are absent. You say, well, how is that a downside? The eyelashes to the upper eyelid perform a function. Every time you blink and close, they're longer, they're thicker, they're batting away debris. If you're in a wind, if you're indoors, it feels like a foreign body sensation because there is no protection from the cilia that are missing. Okay. So one non-surgical acquired forelid lesion is a congenital absence of skin from the upper eyelid, which our dermatologists label lamellar-ichthyosis. And this is a patient who is absent skin of all four eyelids, absent skin, her skin was tightened everywhere. And the skin grafts are actually taken from her sister that did not have lamellar-ichthyosis. But I only am closing with this for one reason. In our field, this used to be multi-stage procedures. You do the upper eyelid, you do the lower eyelid, the child is subject to years of surgery. And the reason for that, skin graft has to be compressed. And if you are going to put a bolster on the upper eyelid, you're closing it. But how can you put a bolster on both eyelids except in stage surgery? Now you have a four-lid patient, you go, well, there's going to be 4 procedures. But what is now commonly done is to skin graft the upper eyelid, to skin graft the lower eyelid. In Engineering 101 or Mechanics 101, the procedure is to take the lower eyelid and stretch it way up under the upper eyelid, exiting above the brow, so it's on the stretch. And then the bolster is just placed on one eyelid, the upper eyelid, so it's transmitting compression to the graft on the upper eyelid, the graft on the lower eyelid, and at least you're reducing the surgery by 50%. Now, congenital lesions can be orbital, and I do believe this is the end of what I have to present, meaning a child with just a mass in the eyelid. And here is a purplish, there are many different locations, many different types. I'm just going to present one of the more common ones, a capillary hemangioma. And it's self-evident on MRI that this is a vascular lesion. It's elevating the globe, and it's occupying the infraorbital space for sure. These are usually removed in open surgery, can be removed using a laser, not through the skin, but on the soft tissue, since it's a vascular lesion, and the outcomes are quite good compared to more complex lesions. So what I've hoped to present is some soft tissue defects. This is a small pigmented congenital nevus that is shaved that do have downsides. This young lady is left without eyelashes. She's left with some pigment. It's a benign lesion, but it clearly has a downside. And contrast this to youngsters who simply have inflammatory lesions. You may know them as chalazions, hordeolums. This is one of those, and they can be shaved and giving you quite a good outcome in the long run. So this was sort of like History of the World Part 1, or Ophthalmic Plastic Surgery 101. The soft tissue defects are to the eyelid, the lashes, absence of soft tissue. The colobomas, or the bony defects that are demonstrated by the Tessier craniofacial system, are more complex and involve the tear outflow system. But I'm sure you're going to hear much more about this from other presentations, and I thank Jim for allowing me to present this. Thank you.